One of the things that's made it challenging is that the criteria for implantation has changed over time. There are more people who are potentially eligible for it based on the criteria that's in the package inserts with the devices and all that. And some people just haven't kept up with what those changes are.
There are 466 million people living with disabling hearing loss across the globe. And despite growing clinical evidence of the benefit of cochlear implantation in adults, it is still sometimes seen as a last resort. Welcome to this episode of Hearing Health Today. I'm your host, Craig Sharp. In this episode, we'll speak with Associate Professor Holly Teagle from the University of Auckland in New Zealand and explore how we can address the growing hearing loss epidemic. We'll also gain a broader perspective on why treatment guidelines and a standard of care for hearing loss are so crucial when we hear from two additional experts in the field, Dr. Leo de Rave, Scientific Advisor of the European Association of Cochlear Implant Users, and Associate Professor Robert Briggs, Head of Otology and Medical Director of the Cochlear Implant Clinic at the Royal Victorian Eye and Ear Hospital in Australia. This is a podcast for hearing health professionals. If you are a person with hearing loss or a member of the general public, please seek advice from your health professional about treatments for hearing loss. Joining us now is Holly Teagle, the Clinical Director of Audiology and Habilitation at the Hearing House in Auckland, New Zealand, with a dual appointment as Associate Professor at the University of Auckland School of Population Health. Well, Holly, thanks for joining us on Hearing Health Today.
Nice to be with you. Thanks for asking me.
Absolutely. It's a pleasure to speak with you. So we always start the podcast by just asking where the interviewees are currently speaking to us from.
Well, I am in my office at Grafton in the university building that University of Auckland Department of Audiology is housed in.
You don't sound Kiwi, so I wanted to sort of get your perspective of how you ended up in New Zealand.
Oh my! Well, no, I'm not Kiwi. I've been here about 2 years.
Right.
Yeah, so just it was a time of life and a good opportunity collided. I came here to be clinical director of the Hearing House, and then also do some teaching and research with the university.
One thing that I've always wondered about the hearing loss space is that the WHO projects that there's over 450 million people with disabling hearing loss, and a lot of those folks could be benefited by a cochlear implant, but it seems like the penetration of cochlear implants is just stubbornly low, and it's really hard to get that penetration a little bit higher. Was curious to get your thoughts and perspectives on why the industry has really struggled to increase the rate of cochlear implantation for those patients who would benefit from it.
Well, it's good to always to think about the positive first, and the positive is that cochlear implants for children is well penetrated, and we're doing a really good job, I think, globally, pretty much, at providing children with device cochlear implants when they need them. So that's really good, and we do. I think are meeting the standard of care for children. It is a different story for adults, and unfortunately, a lot of it has to do with funding. And that's true in New Zealand, it's true in the US as well. But there's also, so that's part of it, but there's also a problem with awareness and understanding what the benefits are. And the lack of awareness about what's possible, I think.
We'll go back to Holly in New Zealand shortly, but I want to bring in two experts from other parts of the world to get their perspective on the difference between pediatric and adult access to cochlear implantation. First, we're going to head to Europe and hear from Dr. Leo de Rave.
In most countries in Europe, pediatric cochlear implantation is going very well. I mean, we have most countries now universal hearing screening, and they are referred to the cochlear implant teams further on. So let's say in general, this is working well. And for instance, I come from Belgium, and in Belgium, more than 90% of our deaf kids receive cochlear implants, of which a high number before the age of 18 months. Yeah. Now, if you compare that with adults, it's totally different. For instance, Belgium and the Netherlands, we know that when we look at the candidature, those who are candidate for cochlear implants, that in adults, this is less than 10%. Yeah. So it's a huge difference comparing to the pediatric population. We have to focus much more on the adult population. There are different reasons for that, of course. One important reason is, of course, also money. Yeah. So if you just have €1 and you have to spend it, do you spend it to a newborn child or do you spend it to an elderly person? Yeah. If you have to make that choice, money goes to the child. So it has to do with money, but much more than money, especially awareness. Awareness, let's say, start with the awareness of professionals. Professionals, I think about audiologists, local ENT doctors, general practitioners. These people have to be informed about what is possible today with cochlear implants. Yeah, and what will happen if these patients are not treated by a cochlear implant. Yeah, we know that hearing loss is going to have impact on a lot of things which are involved in quality of life. Yeah, not only on speech perception, but also on social functioning. You have more chance to get isolated. There's more chance to lose your job. More chance to go for depression. Even the brain is stimulated less, and so it can impact even your cognitive function, and there's even more chance to go to dementia. Yeah. So let's say if there is little or no auditory input, it's influencing the brain. Yeah, and the brain is connected to a lot of other functions. So it's really a kind of, I call it a kind of domino effect that you create if you're not treating hearing loss.
And now let's hear from Associate Professor Robert Briggs from the Royal Victorian Eye and Ear Hospital in Australia.
I think for the Australian-New Zealand market, whilst we have internationally quite a high rate of penetration for cochlear implants, it's still lower than it should be. And again, I think this comes down to largely awareness in the general population and also among the hearing health professionals who often are unaware of the current candidacy, and so having appropriate guidelines will make a big difference. We know that there's a lot of potential recipients who are unaware of the benefit of cochlear implantation, and also hearing professionals who don't refer or are unaware of the benefits of referring. And so I think they should be reassured that cochlear implants are remarkably effective and that the surgery is very straightforward and nothing to be afraid of.
And now let's cut back to Holly in New Zealand. Have you seen anything be effective in helping boost the awareness for cochlear implantation in adults?
Well, I think one of the things that's been that's made it challenging is that the criteria for implantation has changed over time. When you think about it, the industry is about 30 years old. And when it was first, came on the scene, it was investigational and took some years to amass, a good bunch of data that was really supportive of outcomes. And then over time, the criteria has opened up so that there are more people who are potentially candidates or sort of are eligible for it based on the criteria that's in the package inserts with the devices and all that. And I think some people just haven't kept abreast of what those changes are. So these changes in technology have a knockdown effect and create changes in candidacy. And some people just haven't kept up with what those changes are. So the devices that we have today, the CI devices that are available today, are really quite amazing in terms of all the additional thing. And so in addition to just creating good hearing, there's streaming functions and all that. So I think we need to really increase awareness, not just around the fact that you could hear better, but you can hear better in a lot of different environments. And then all the other secondary quality of life benefits that come along with better hearing and better communication. So it's messaging. We need to do some more messaging and get people up to speed.
And how about like direct to patient or direct to candidate communications, I guess? Is there like an opportunity for improvement there? And I guess who do you think sort of would be most effective at conveying that information?
Well, I think in New Zealand, it seems to me that, again, we take really good care of our children. And then as adults get older, they may seek out private care for their hearing needs. And there may not be sort of a coordinated effort or coordinated message among audiologists, or simply people just aren't getting those referrals to see an audiologist. So if an adult sees their GP only when they're ill and doesn't go every year, doesn't have a good routine of quality health care follow-up, they may not ever get identified as having a loss that could be impacted by hearing technologies. And so I think, again, it's about messaging and about people knowing, and I think in any situation you have to have support from your family and friends, and to also say, why don't you go in and have your hearing test, or I think you're having troubles, or encouraging people to investigate, is there a way that they could have improved hearing.
And one thing that I've also heard thrown around is people often talk about hearing loss not being medicalized. What does that mean? Sort of, what do people mean when they say that?
Yeah, well, hearing loss is typically related with aging. Most forms of hearing loss is, and it's considered a invisible handicap because you don't look at people and say, oh, you have hearing loss. And so it might be that that could be part of that medicalized point of view. If you don't have a clear pathology, you don't have an ear infection, or you don't have a tumor, you don't have a surgical issue, you just have hearing loss that's secondary to aging, which is very normal and natural, then it may not get that sort of medical label put on it. And if it doesn't have a medical label, then there may be, people don't see it as something as treatable or as easily treated.
I wanted to go back to something you said earlier that I thought was really striking. So you said that for the most part, the industry, the community is doing a good job catching pediatric patients that have hearing loss, but perhaps not as good of a job on adults. And I'm just curious, around that referral pathway, why is that easier for children and a little bit more challenging for adults? Many
countries, have recognized that newborn hearing screening protocols are really making a difference in terms of early intervention, getting children access to hearing technologies when they need them earlier, and then that has a cascading impact on their speech and language, their academic, social, vocational, all those things. And so because we have the newborn hearing screening, and then in New Zealand we have a sort of a before school screening program, as well as do a lot of other countries. So your opportunities to pick up early childhood hearing loss are pretty good. And also, if you've got a regular schedule of intervention with a pediatrician, or you're doing well child checks, usually there's questions around that. So when we get to be adults, we don't get to have well adult checks maybe as often as we should. Yeah.
Is there a place for, I guess, maybe like an adult standard of care, or sort of some more defined set of protocols for adults that would help alleviate that?
Yeah, well, I think I think we need to attack it from a lot of different angles. So it needs to be kind of a grassroots effort, in that we need to that people to know that if they're having trouble, there's technologies that can help them. But then we also need to go to all of the other medical care providers or associated professionals, nurses, OTs, PTs, whoever are seeing the aging population, really, gerontologists, and make sure that they have all the information and knowledge that they need. So, there are support groups for people with hearing loss, and most of the people that are involved in those are already pretty tuned in. That's why they belong to the organization. They care, and they've sort of discovered better hearing through technology. But they can be great avenues of information for other people too. And so just having social functions and media events and things like that, just to call attention to it, another way, I think, to help.
Hearing loss is associated with aging, as are a lot of other chronic conditions. Where do you think hearing loss sits sort of in the hierarchy of different conditions that like a gerontologist or a primary care provider might be screening for in that age population?
Yeah, that's a really good question. I mean, I think that we look at things like blood pressure and cholesterol and, a lot of the metabolic changes that we know happen with aging. And vision, of course, is a real obvious one. There's oftentimes there's screening for visions. You don't get your driver's license if you don't have a vision screening or pass that test. So for some reason, it's just hearing just hasn't been weighted as highly, and it's not universally. I do think there are some GPs and gerontologists who will prioritize and ask about it, but then I just don't know if the next step happens where they get referred and evaluated, and that there's actually a action.
Are you aware of efforts by, I guess, professional bodies or countries or maybe even patient advocacy groups to make that a little bit more formal, sort of what that process might be?
There's been a lot of talk around that, and I think the evidence for the need for that is definitely mounting, and it could be something as simple as a 5-point questionnaire that a physician would ask. Do you have trouble on the phone? Do you have trouble hearing from a distance? If you don't see someone's face, can you understand what the message is? Just some of those kinds of questions are good screening questions.
It's interesting you say that. I actually used to work in obstetrics. And in postnatal care, I think one thing that occurred when I was working with a large practice group back in the States is that we introduced sort of a 5-point questionnaire for postpartum depression as part of every postpartum visit, which wasn't standard before, but now I think is quite routine. How do you think COVID might affect adults, specifically seeking access to care for hearing loss?
That's really interesting, I think. Because depending on our situations and being in bubbles, right, because we've had to self-isolate, some people, I think it has really kind of brought them to front of mind that when you are alone and you don't have a lot of communication partners, life can get kind of sad and lonely. And I think it does sort of, it makes you realize that when you don't have face-to-face personal contact with people, your quality of life goes down. And people compensate when they have hearing loss. They compensate by getting closer and lip reading and having more sort of close contact. And so I wonder if there won't be people that having gone through the lockdown and everything associated with COVID, that they're not feeling a little bit isolated and lonely. And sort of that's been compounded by the fact that they have hearing loss. We can only hope that when people do get comfortable and are back out and life returns to normal, that maybe they will follow up on some of those things.
I'm curious, in the Hearing House, do you guys see folks all the way from mild hearing loss through to severe and profound, or do you guys mainly focus on the severe to profound spectrum?
So we're definitely a referral center for severe to profound. So we wouldn't be seeing folks with milder levels unless it was in the other ear. So we do have a lot of our adults do continue to wear hearing aids in the opposite ear, and so we will monitor and manage those as well. But typically it's just CI recipients.
Have you seen a particular set of clinic guidelines or clinical guidelines that have worked well, either in your current role in New Zealand or somewhere else that really does sort of help inform that referral pathway?
I saw something recently from a talk that was from the US that talked about a 60-60 guideline. Basically, it was referring to 60% word understanding and a pure tone average of 60 dB, and so it kind of as a screening tool. So that's something that I think is a good shortcut to who might be a candidate. So I thought that was a good tool.
What does sort of candidacy criteria look like? Like, how complicated could it be? So if you were a referring professional, either an audiologist that primarily treats hearing aid patients, or like a gerontologist or a primary care provider, like is it something based in its current form that would be like challenging to to really know all the ins and outs, and maybe we need to look for something simpler, or actually it could be quite simple?
Well, I think if you just think about, rather than looking at like what the candidacy criteria is for, a certain country or a certain device or whatever, if you just think about it, is one way of thinking about it is, would this person do better with a cochlear implant or a hearing aid? You have someone with known hearing loss, and which would they do better with? And if with hearing aids, they're wearing them, they're understanding speech, they're communicating, they're enjoying life, they're listening to television, they're hearing, for the most part, they're functioning well, and they have good quality of life, then you feel pretty good about them continuing wearing their hearing aids. And everyone, or most people who have hearing aids would have regular assessments, and if there were change, then you could make adjustments. But I think some of those, just that basic question is your hearing, are you able to do what you want to do with the current hearing that you have? And if the answer is no, if you're not able to understand well and communicate well and enjoy music and enjoy television and theater and all those things, then there's potential that you should be evaluated and see if there's a solution. Not everyone that comes to the hearing house walks out with a cochlear implant. Even if there were no waiting list, because there's some people who haven't maybe maximized the fitting of their hearing aid and the other assistive technologies that might be available to them. We want to refer people so that they know about it. They know it's there. It's a safety net. If it's not appropriate now, it might be later. But, not everyone's going to actually meet the candidacy requirements that's based on their ability to repeat words and sentences. That's mostly what it is just those kinds of audiologic speech perception tests is what we rely on.
So that's sort of something interesting that you just said, that you'd encourage referrers to refer people that might not be ready for a cochlear implant yet, but maybe would be sort of in 6 months or a year, to just sort of get them familiar with the process and what this could look like?
Well, and there's data that suggests that most people are a candidate for up to 15 years before they actually get in the door of a CI center. So I don't think we would be jumping the gun if we encouraged people to go and find out about it sooner than they might think. Yeah.
So then in some cases, when someone is referring someone, I guess, earlier than they normally would, they might actually be referring them sort of at the appropriate time for a cochlear implant then. Yeah,
could be. People with hearing loss some people with hearing loss get very good at adapting. Your hearing, you may have a sudden hearing loss where you go from good hearing to poor hearing, but in general, it's more likely that you're going to have a decline in hearing over time, and you adapt to it. You use other behaviors and other strategies to kind of compensate. And so I think some people don't appreciate how much trouble someone's having until you get them in a test situation where there's not visual clues, to help them understand. Yeah.
I know. It's like I used to be a really fast runner. I'm no longer a fast runner, but I don't notice it until I look at the times that I actually compare the same route.
Yeah.
What do you think is one thing that would make the single biggest difference in hearing healthcare around the world? Specifically, if we're looking at this with a frame of how do we get more people to get the appropriate level of treatment, if you could wave a magic wand and say, there was one wish that you got to help improve access and awareness to hearing healthcare, what do you think would make the biggest impact?
Oh, goodness. One thing. See, I think it's not a simple problem. There are multiple needs around it. So yeah, raising awareness, funding, understanding and appreciation for what the technology can do and how sophisticated and yet simple it can be to use. I don't have one thing. Sorry, Craig. I can't think of one thing. I mean, it's I think it's, the message is awareness. I suppose that's the one thing, awareness. Yeah.
I believe that you do some work with an organization called Pindrop. Is that correct?
I have, yes.
Could you, I guess for the benefit of the listeners around the world, explain a little bit more about Pindrop and sort of their mission?
Yeah, so Pindrop Foundation is an advocacy group for adults who have hearing loss, and their primary goals are to increase access to hearing technologies, mostly cochlear implants. So they've been active in New Zealand, I think, for many years, and they do work with ministry and try to bring the issue to the forefront with media and doing different things like webinars, and so that's we do have this advocacy group, but I think I think there's more that we could do. I know that the CI centers, there's the Southern Cochlear Implant Program, as well as then the Hearing House, and we all have very satisfied people who are living better lives, and we need to encourage them also to be out there, and that's happening. The Hearing House has an consumer advisory group, and we're listening to them and trying to work with them and find ways to raise awareness. We've done something. Loud Shirt Day has been an event that's been.
What's Loud Shirt Day?
It's been
Tell
awesome
us a little bit
event.
more about that.
Yeah, so it's Loud Shirt Day is an event that's been going on for many years here, and it's it's exactly what it sounds like. You wear a very loud shirt, colorful shirt, but it's a huge fundraising event, and it's been centered around children. But now at the Hearing House, we've aligned our adult and children. We're all under one roof now, and so we're still doing Loud Shirt Day, but it's not just for children; it's for children and adults. So a lifespan program to raise funds for Kiwis who need cochlear implants.
Do you have a particularly favorite Loud shirt that you go to?
I have one. Yes, I do.
All right.
It's a mandatory purchase. Yeah, if you're going to be in part of Loud Shirt Day, you've got to make a statement and get a good one. Yeah.
I like that. Loud Shirt Day. That's a really great initiative. So maybe for folks around the world where there isn't a Loud Shirt Day, they can learn from the Kiwis and implement. Yeah. I know we touched on this a little bit earlier, but I was, since, it's all over the news these days, the COVID-19 pandemic, just curious about what advice you might have for other hearing care professionals that are trying to treat patients and keep up with their patients during this pandemic.
Yeah, there have been really good guidelines that have been developed by the New Zealand Audiological Society, and the Ministries of Health have also offered good guidelines. The Hearing House was considered an essential service because it was important that people remain on the air with their hearing so that they could know what was happening when announcements were happening about where the state of things were relative to COVID. So, I guess I would just reassure people that audiologists, as healthcare providers, are taking the same kinds of precautions that they're going to see in other medical settings where we're, doing all the hand washing and gowns and masks and distancing when we can. It's kind of challenging to distance when you need to look in someone's ear, but there are a lot of precautions in place, and I would hope that people could, when they're comfortable, get back into the clinic and get the audiology care that they need.
What's the most important thing that you've learned throughout your time working in hearing healthcare? Well,
it's been amazingly rewarding and satisfying career for me. So just personally, it's been so great to be part of the lives of people and children and adults and see how their lives can improve with better hearing. And when you watch a baby who is deaf learn to talk, and it's amazing. So communication in itself is such a vital part of being human. In human relationships, and when you don't have good communication, life's just not as good.
Well, Holly, it's been a pleasure to speak with you today, and we really appreciate you taking time out of your day to join us on Hearing Health Today.
Well, you're so very welcome. It's been wonderful to be talking with you.
And thank you for listening to today's podcast. If you enjoyed it, please make sure you press the subscribe button and give us a rating and a review. If there's a particular topic you'd like us to cover, please mention it in your review. We'd love to hear from you. You can find all the links to what was discussed in today's podcast in the description, and stay tuned for our next episode. In the meantime, stay safe. Just a quick reminder, the views of the interviewees in this podcast are their own and do not necessarily represent the views of Cochlear Limited or its subsidiaries. This material is intended for health professionals. If you are a consumer, please seek advice from your health professional about treatments for hearing loss. Outcomes may vary, and your health professional will advise about the factors which could affect your outcome.